So this case is based on that only. And so here is a 56-year-old male known case of CKD since 2010 with diabetes mellitus for 15 years. He had diabetic retinopathy, diabetic kidney disease, normal size kidneys, of course, because he had DKD, and hypertension for 4 years. And he was later on declared ESRD. So first of all, when he presented to us in 2010, he presented with the drop in urine output, the rise in creatinine, along with generalized weakness, anemia, edema, vomiting, and anorexia. His appetite worsened progressively and became weak and appeared to be moderately malnourished. This is his biochemical profile here. You can see that hemoglobin is 6.2, TLC, DLC, and all those. And then serum creatinine it was 3.8, the first column. The sodium was 138, potassium was borderline 5.2, calcium was 7, which is low, phosphorus was 5, which is high for a pre-dialysis patient, and protein was 6.8, serum albumin was 3.5. Okay, so here you see this is a patient with compromised nutritional status. So what happens here is the patient's nutritional intake from June 2010 to January 2011 was only 0.4 grams per kg body weight per day of protein as per 24-hour dietary recall, and his energy intake was less than 20 kilocalories per kg body weight per day. So this is a really low intake because the patient had lost his appetite. He was not eating very well, and he was not being given keto analogs. So if he had been on keto analogs with 0.4 grams per kg body weight per day, remember the very low protein diet, he would have done very well. But here he was only on 0.4 grams per kg body weight per day. So the diet prescription was given according to KDOQI guidelines, and so he was not meeting the diet prescription, and he was being maintained on a conservative management. So according to the food intake, what is the nutritional status of this patient? Is he well nourished, mildly malnourished, or moderately malnourished, or severely malnourished, or none of the above? Would you like to comment, boys and girls? Or shall I continue? Okay, so this patient is moderately malnourished. Now when the patient comes to you, what is the first thing that you ought to do is the nutritional screening. Now let me tell you, the moment the patient enters your clinic, and the way you see your patient, the moment you see your patient should be able to make out whether he is malnourished or not. Even if he sits like this, you can't see my video. You just have a look at his wrist. Whether he has any fat left or not, you will be able to make out whether the patient is malnourished or not, okay? And they are, I do not have time to teach you that, to tell you that, not teaching, but tell you that. But yes, there are a lot of, landmarks where you can focus and see if the patient has got enough fat or not. I'm sure you all know about it. So nutritional screening is a process of identifying patients at risk of malnutrition so that more extensive nutritional assessment can be performed. So all you have to do is, it's a simple and rapid process. You just have to ask him whether he has had a recent weight loss, current body mass index, disease severity, and recent food intake. I think the lecture you had yesterday by Dr. Ved Prakash, he did talk about nutritional screening, and he did tell you about the various tools. So I'm not going to go into that detail. Now, nutritional assessment is a detailed diagnostic process which characterizes the degree of malnutrition, the risk of medical complications related to malnutrition, and the need for nutritional support. It is used to monitor the course of nutritional therapy. So as I said, you can actually make out when the patient walks into your clinic whether he is malnourished or not. Now, the diagnostic criteria for protein energy wasting, which we use in renal nutrition, is the International Society of Renal Nutrition and Metabolism's criteria, which has 4 criteria: the serum chemistry, the body mass, the muscle mass, and the dietary intake. Out of these 3 criteria, at least 3 have to be present, and out of these 3, at least 1 has to be present in order to say that the patient is having protein energy wasting. So serum chemistry includes serum albumin less than 3.8 grams per deciliter, serum prealbumin less than 30 milligrams per deciliter, and serum cholesterol less than 100 milligrams per deciliter. And you know that if the serum cholesterol is less than 100 milligrams per deciliter, it surely is, it's pointing towards high risk for mortality. So, and body mass index, if it is less than 22 and the patient is more than 65 years, and if it is less than 23 and the patient is less than 65 years, then it is like the patient is having some problem. Or if the patient has had unintentional weight loss of 5% in 3 months or 10% in 6 months, and the total body fat percent is less than 10%, then he is a potent candidate for malnutrition. Okay, and if the muscle mass is he's showing muscle wasting, that is reduced muscle mass of 5% in 3 months, in 3 months, or 10% in 6 months, or if he has reduced mid-arm muscle circumference area of more than 10% reduction in relation to the 50th percentile for the reference population, then he is a candidate for protein energy wasting. And most importantly, the dietary intake, because our patients tend to be anorexic, they do not eat very well. So if there is unintentional low dietary protein intake of less than 0.8 grams per kg body weight per day for at least 2 months for a patient who's on maintenance hemodialysis, and for a patient who is in pre-dialysis stage, that is, and the dietary protein intake is less than 0.6 grams per kg body weight per day, in stages 2 to 5 with 5 grams per day of urinary protein loss, then you know that the patient is malnourished. And if the patient has an unintentional low dietary energy intake of less than 25 kilocalories per kg body weight per day for at least 2 months, then you know that malnutrition is impending. Now, this is the pro forma for subjective global assessment, and I'm sure you all must be aware of this, that it has two components, the medical history and the physical examination. The medical history includes the weight changes, the dietary intake, whether the patient is having a suboptimal solid diet, hypocaloric diet, full liquid diet, or starvation, or whether the patient has gastrointestinal symptoms or he has functional impairment. And then physical examination is that you examine the patient for loss of subcutaneous fat, muscle wasting, edema, and ascites. And then the patient is rated as well-nourished, mildly or mildly or moderately malnourished, or severely malnourished. Okay, so and now moving on to our question: what are the important independent nutritional risk factors for what is this? I can't see. I have to move this. Anyway, which reflect malnutrition. All right. Anyways, so are these serum albumin levels, low SG scores, low normalized protein intake, low BMI, or all of the above? So here answer is all of the above, because all of these are reflecting malnutrition. And so these are the risk factors for mortality in our patients. Now, what is low protein diet? Does it mean 0 or no protein intake, or does it mean 1.2 grams per kg body weight per day of protein, or does it mean 1.5 grams per kg body weight per day of protein, or does it mean 0.5 to 0.6 grams per kg body weight per day of protein, or none of the above? So here, this is a low protein diet is 0.55 or 2.6 grams per kg body weight per day of protein. Right. Now here, if you have a look, the patient has a low serum albumin of 3.5. So he's actually malnourished. And what should be the protein intake? What should be the diet prescription for this patient? Should it be 0.4 or 0.55 to 0.6 or 0.8 or 1 gram per kg body weight per day of protein, or none of the above? Well, this patient should be kept on 0.6 grams per kg body weight per day of protein. And energy intake for this patient should be 30 kilocalories because he happens to be diabetic. Now, sodium intake for this patient should be less than 2.4 grams per day. And of course, he has to refrain from canned foods, fruits, pickles, fruit jams, processed meat and cheese, because these all contain sodium as preservative. And potassium intake for this patient, because he is on conservative management, should be less than 1 milliequal per kg body weight per day. And here you can see that potassium here is 5.2. So you'll have to tell the patient to take absolutely no fruits. And now, after the patient has recovered and he is no more hyperkalemic, the fruits that you can allow this patient to take are apple, banana, papaya, pear, guava, and pineapple. And because these are fruits with the low potassium level, that is, they are less than 100 milligrams per 100 grams of the the mass. Okay, so these are safe for our patients. You should never give them watermelon. Do not advise them pomegranate. Do not advise them quinoa or malta or musami, because these are very high in potassium. Now, the vegetables which you can allow our patients to eat are lauki, turai, bhindi, parwal, potato. And as I mentioned the other day, bhindi has soluble fibers. It's really, really good for our patients. And how much dietary phosphorus would you allow this patient? You would allow him to take 800 to 1000 milligrams of phosphorus. And along with that, you will have to put the patient on the phosphate binder. Okay. And calcium intake should not exceed 2000 milligrams per day because of the fear of soft tissue calcification. And if the patient is on vitamin D analogs, then you have to restrict calcium intake to less than 1200 milligrams per day. Now, to prevent metabolic acidosis, you will recommend sodium bicarbonate, that is 1 gram per day, which is to be given TID. And you have to maintain serum bicarbonate at more than 22 mmol per liter. And so the conservative management of this patient is that he is on a low protein diet and he's a diabetic, so energy intake is 30. And well, I think I've already taught you everything in the previous slides. So what kind of diet, what is the menu for this patient? If he's 50 kgs in weight, and if you want to give him 0.6 grams per kg body weight per day of protein, then you are going to allow him about 30 grams of protein. So you can allow him to take 150 ml of milk. Why? Because milk is a protein of high biological value. And dal, 1 bowl, curd, 100 ml, chapatis, about 8 chapatis. Provided your patient is able to take that. If he doesn't take 8 chapatis, you can increase the amount of milk that you're giving to your patient. Rice, 50 grams. Or if he wants to have more of rice, you can reduce the number of chapatis. Egg white, and that will bring you to close to 30 grams of protein for your patient. So this is pretty safe. Now, if you are putting your patient on a very low protein diet with keto analogs, then this means you're going to give him 0.4 grams per kg body weight per day of protein, or maybe 0.5 grams per kg body weight per day of protein, along with 6 tablets of keto analogs. So in that case, you have to give your patient a very high calorie diet. So if your patient is weighing 50 kilo, and if you're giving him 0.4 grams of protein per kg body weight per day, then the protein requirement for the patient is only 20 grams, and the rest is taken care of by the keto analogs. So milk here, in this case, you will give him, reduce it to 125 ml, dal 1 bowl, because see, Indians do prefer dal when they have rice and chapati, so you can't cut down on dal. Chapati 7 or whatever, whichever way, and then you can exchange rice with 2 chapatis, or you can exchange it with 1 egg white in place of rice. So that would be preferable because 1 egg white will give him protein of high biological value. So the total protein intake will come down to 20 grams per day. And you can exchange milk, say 100 ml of milk with 1 egg white, because both 100 ml of milk contains 3 grams of protein, egg white also contains 3 grams of protein, and 100 ml of curd also contains 3 grams of protein. So this way you can change you can use the exchange list. Now, moving on to this, the medical history of the patient. In January 2011, the patient appeared again, and he got admitted with complaints of vomiting, breathlessness, generalized weakness, and swelling. And he was declared ESRD and had first dehemodialysis in the month of January 2011. So now, when he presented to us, he came with a serum creatinine of 12, sodium of 138, potassium of 4.5, which was well controlled, but calcium was reduced. Phosphorus was very high, 8.9, which means that during the conservative management, he was not taking phosphate binders. Otherwise, it wouldn't have gone to 8.9. And then serum protein level was 5.4, so he is malnourished, which has come down from 6.8 in 2010 to 5.4 and the serum albumin has also come down to 3.3, and anyways it is less than 3.8, and ISRN criteria says the serum albumin should be maintained above 3.8. So here he had his first dialysis, and then later on in February he shifted on to CAPD, and by then, because he was on hemodialysis, you can see the way his serum albumin and proteins are going down. But it is only after he came on CAPD that he started eating so very well, and also that he was getting plenty of energy from the dialysate, the glucose dialysate, that his intake, the protein intake also increased, and his serum albumin started increasing. But later on, he literally collapsed with peritonitis. I'm going to talk about it later. So malnutrition, if it is present at the initiation of dialysis, is a strong predictor of relative risk of death. And here we see how our patient was doing. So we have to maintain serum albumin at more than 4 grams per deciliter, and serum pre-albumin at more than 30 milligrams per deciliter. So to ensure neutral nitrogen or positive nitrogen balance for a clinically stable dialysis patient, dietary protein intake should be 1 gram per kg body weight per day if he's on hemodialysis, and 1.2 gram per kg body weight per day if he's on PD. And so here this is a very busy slide where what are you going to prescribe to your patient if he's 50 kilograms and you want to give him 1.2 grams per kg body weight per day of protein. Then you can increase the milk intake to 200 ml curd. And remember, these patients on dialysis, most of them are anuric or maybe oligonuric. So you have to be careful about their fluid prescription. So instead of milk, you can prefer more of paneer for them, so that they eat more of solids and they can keep that little bit of fluid, whichever is left, for them to take, if they're feeling thirsty, or them to take drugs. So curd you can increase to 200 grams, dal you can always give them 2 bowls, fish 25 grams, or chana, roasted chana 3 grams. Chapatis, eight chapatis. I mean, I would be surprised if patients do take 8 chapatis. Bread slices 2 along with porridge. I mean, this is something like a slash means either bread slice or porridge. Rice, see, 1 bread slice will give you 1.5 grams of protein, and 1 chapati will also give you between 1.5 to 1.75 grams of protein. So you can exchange them, rice with starch, in order to give him more of calories. Or if the patient is diabetic, then you will tell him not to take starch wala rice. And the egg white, of course, you can give him 2 egg whites, at least 2 egg whites. I would suggest you can, I always want my patients to take 2, 3, 4 egg whites, because that is not taking any cholesterol with the egg whites. So that is pretty safe, and it's getting a very good amount of amino acids through this. And paneer, at least 100 grams, which will give 13 grams of protein. Fruits, 50 grams, provided the sodium serum of potassium is less than 5 milligrams per deciliter. And phosphate binders will have to be taken with meals. We just saw, I said, he was on medication for 1 year on conservative management, but his serum phosphorus had gone up to 8.9, which means the patient really was not taking phosphate binders. So total protein intake this way will be 64 grams. Energy will be 1500 to 1600 kilocalories. Potassium will be 60 milliequal, and phosphorus will be about 840 milligrams, which is actually fitting into what keto guidelines recommend us. And then if the patient, when the patient was initiated on PD, he started eating very well, but the patient went into a hypercatabolic state. With the maintenance hemodialysis, his proteins and serum albumin came down, and he was having, he had 3 episodes of peritonitis, and eventually the catheter was removed. So when the patient is on PD, he has to take even more protein, because the losses in PD of protein every day are to the tune of at least 15 grams a day. So in 24 hours. So therefore, he has to be kept on a very high protein diet. So in this case, you can increase his protein intake, and the patient will have to be put on oral nutritional supplements, because otherwise it will not be easy for patient to take enough of protein. And this is all about the case, and thank you for your attention.